Hello everyone. Today our topic is breast or otherwise called as mammary gland. Okay. So let us start. So this could be asked as an essay question. Okay. Or sometimes a particular topic in a short note. Right. So let us also see how we have to present this in the exam. So starting off, we are going to start off with the introduction. So breast is the most important structure present in the pectoral region. So it is present in the pectoral region. Second point, it is a modified apocrine sweat gland that is present in the superficial fascia of the pectoral region. So first point, it is present in the pectoral region. Second, we will be writing it is a modification of what? It is a modified apocrine sweat gland. And we all know it is present in both male and female. However, it is going to be rudimentary in male throughout their life. But whereas in female, during puberty, it is going to develop. So occasionally, in rare occasions, the breast of male is going to become enlarged, and this condition is called as gynecomastia. And in females, it forms accessory sex organ of the reproductive system, and it provides milk to the newborn baby. And the primary function of breast in female is to nourish the infant. So first point in the introduction will be it is present in the pectoral region. Second point, it is a modification of what? It is a modification of it is a modified apocrine sweat gland. And the third point, it is going to be present both males and female. In male, it is going to be rudimentary, but in some rare occasions, it gets enlarged and the condition is called as gynecomastia. In females, it is a sex organ, accessory sex organ, and it is used to provide milk to the newborn babies. Okay, so these points are going to be the introduction. Next, coming to location. So the second topic will be location. So the breast is located in the superficial fascia of the pectoral region. Atop the pectoralis major muscle. So pec means chest muscle. So on top of your pectoralis major will be the pectoral, on top of the pectoralis major we have the breast. A small extension of the breast tissue from its superolateral part is called axillary tail of Spence. This is going to pierce the deep fascia and extend into the axilla. So here we have a small extension like this. Okay, so this is called the axillary tail of Spence. So it is a small extension of what? Of the breast tissue that is going to pierce the deep fascia and it is going to extend into the axilla. Okay, so it is going to pierce and extend till the axilla, and it is an extension of the breast tissue itself. The aperture in the deep fascia through which axillary tail passes into the axilla is called the foramen of Lange. So this aperture through which it is going to pierce is called as foramen of Lange. The aperture in the deep fascia through which the axillary tail of Spence is going to pass into the axilla, that aperture is called as foramen of Lange. The axillary tail is the site of high percentage of breast tumor. So a high percentage of breast tumor occurs in this axillary tail. So when we put the topic location, what are all the things that we are going to write? So first, it is present in the superficial fascia. It is present in the superficial fascia of the pectoral region. And then we have to write about the axillary tail of Spence. Okay, this axillary tail of Spence, which is a small extension from the breast tissue in the superolateral part, it pierces the deep fascia and extends into the axilla. Third, you will write about the foramen of Lange. So foramen of Lange is the aperture in the deep fascia through which the axillary tail is going to pass into the axilla. And the fourth point you are going to write as axillary tail is the site of high percentage of breast tumor. So these are the 4 points that are present in the location topic. Next, we are going to the shape and extent. Okay, so the next topic is shape and extent. So shape, we all know it is a hemispherical bulge. Okay, so shape is hemispherical bulge. Shape, it is an hemispherical bulge, and extent is vertical extent, horizontal extent. We are going to talk about two extents. So vertical extent is from above to below and horizontal is like this. Okay. So vertical, it extends from the second rib to the sixth rib. So remember, we have here the ribs, right? So this is the second rib and here we have the sixth rib. So in between, from the second rib to the sixth rib, you are going to have the breast. So that is the mammary gland. Okay, so it extends from the second rib to the sixth rib. Now this is vertical extent. Now horizontal extent, it extends from the lateral border of the sternum. So here we have our sternum, right? So this is the lateral border of the sternum to the mid-axillary line. So this line over here is the mid-axillary line. From the lateral border of the sternum to the mid-axillary line is the horizontal extent. From the second rib to the sixth rib is the vertical extent. So here in the shape and extent, we have the shape is hemispherical bulge. Extent, vertically it is going to extend from the second rib to the sixth rib, and horizontally it extends from the lateral border of the sternum to the mid-axillary line. So in this image here we can see this is the clavicle, this is the sternum, this is the second rib, this is the sixth rib. So this is the vertical extent, horizontal extent from the lateral border of sternum to mid-axillary line. So this diagram can be drawn for location and extent. So here we have the breast, we have the nipple, and we have the areola, and inside we have the nipple. So here this is the axillary tail of Spence as we studied earlier. It is nothing but a small extension of the breast tissue from its superolateral part, which pierces the deep fascia and extends into the axilla. So this is the axillary tail of Spence, and through which it is going to pierce is the foramen of Langer. So this diagram can be drawn. So here if we see, this is the chest wall, and here we have the clavicle, subclavius muscle, and here we have the pectoral fascia enclosing the pectoralis minor, and then we have the pectoralis major muscle, and then we have the pectoral fascia. Then this space between the pectoral fascia and the breast is called as retromammary space. Okay, so retro means behind, mammary means the mammary gland. So behind the mammary gland you have a space called as retromammary space. And this is breast, areola, nipple. So this is the deep relations of breast. We'll be studying that now. Okay. So coming to relations. So the next topic is relations. We saw introduction, we saw the shape, location, and then the shape and extent. Now coming to the relations. So deep aspect of breast is related to the structures from superficial to deep, pectoral fascia, and then three muscles. So the relations of mammary gland, you have to first write the pectoral fascia. The deep fascia covering the anterior aspect of the pectoralis major. So here we have the pectoral. So this green color line that is covering the pectoralis major muscle is called the pectoral fascia. So this pectoral fascia is forming the deep relation of mammary gland. Okay, the deep fascia covering the anterior aspect of the pectoralis major. Next is the three muscles. So this is the pectoral fascia is superficial. Deep we have the three muscles: pectoralis major, serratus anterior, and external oblique muscle. So we have the pectoralis major muscle which can be seen here, and we also have two other muscles. What are they? Serratus anterior and external oblique. So PSE. Remember, pectoralis major, serratus anterior, and the external oblique muscles. Okay, so here you can see pectoralis major muscle which is covering the pectoral region, and then we have the serratus anterior muscle and the external oblique muscle. Okay, so these are the deep relations muscles. So if they ask about the relations, we have, it is related from superficial to deep. We have the pectoral fascia, the deep fascia covering anterior aspect of the pectoralis major muscle, and then we have three muscles: pectoralis major, serratus anterior, and external oblique muscle. Okay, so breast is separated from the pectoral fascia by retromammary space which is filled with loose areolar tissue. So here we saw the mammary space. So this green color is the pectoral fascia and here is the mammary gland. Both are separated by this space called as retromammary space. And this retromammary space is filled with loose areolar connective tissue. Okay, loose areolar tissue. So because of the presence of this loose areolar tissue deep to the breast, it can be moved freely up and down and from side to side over the pectoral fascia. So this allows, this space filled with loose areolar connective tissue allows the movement of breast up and down and from side to side. Okay. Next is the structure. So coming to the structure, breast consists of three components. So what are they? SSP, that is skin, stroma and the parenchyma or glandular tissue or mammary gland proper. So while explaining the structure of the breast, we have three important components that we have to discuss. Okay, one is the skin, other is the stroma and then the parenchyma. So starting off with skin. In the skin, we are going to see nipple and areola. Okay. So again in the skin we have two. One is nipple and areola. Okay. So we have skin, stroma, parenchyma. In the skin again we have nipple and areola. So starting off with skin. It is the covering for the breast and present the following features. So it is going to cover. Skin obviously has a covering or protective ability, right? So it is going to cover. And starting off with nipple, it is a conical projection. So nipple is a conical projection below the center of the breast, usually at the level of 4th intercostal space. So what is the extent, vertical extent of breast? From the 2nd rib to the 6th rib. So in between we have the 4th intercostal space. So 4th intercostal space is where you can find the nipple. It contains smooth muscle, okay, which can make the nipple smooth muscle fibers. So these smooth muscle fibers can make the nipple stiff and erect, or it can flatten it. So it is richly innervated by sensory nerve endings. So sensory nerve fibers endings you have here. So it is the most sensitive part of the breast to tactile stimulation and become erect during sexual arousal. So in the nipple part you have approximately like 4 points to write. The first point is it is conical projection. Second point, where you can find it in the 4th intercostal space. Third point, it is going to contain smooth muscle fibers which can make the nipple stiff, erect and or it can flatten it. So fifth point is it is richly innervated by sensory nerve endings. So if there are more sensory nerve endings, that means it is the most sensitive part to tactile stimulation. Okay. So more is the sensory nerve endings. It is more sensitive to the tactile stimulation and it is going to become erect during sexual arousal. Right. So this is about nipple. Next we have the areola. So areola is a circular area. Okay. So nipple was a conical projection, whereas areola is a circular area of pigmented skin surrounding the base of the nipple. So it is going to surround the base of the nipple. It is a circular area containing pigmented skin. So it contains large number of modified sebaceous glands. So breast as a whole, it is a modified apocrine sweat gland. So adula areola you have. So this areola contains modified sebaceous glands. Okay. So it contains large number of modified sebaceous glands. Sebaceous glands. Okay. Particularly over its outer margin. So what are these glands going to do? They are going to produce some oily secretion which are going to lubricate the nipple and the areola. That prevents them from drying and cracking. The color varies from complexion of women During pregnancy, it is going to become darker and enlarged. Okay, so this is about areola. So about areola, the first point, it is a circular area and it is a pigmented skin surrounding the base of the nipple. So first point done. Second point, it is going to contain large number of modified sebaceous glands which are going to produce oily secretion that are going to lubricate the nipple and areola. Fourth point, it is going to vary from complexion of women to women, and it is during pregnancy it becomes darker and enlarged. Okay, so now we have done with the skin, both nipple and the areola. Okay, so nipple conical projection, fourth intercostal space, has smooth muscle. It can become stiff, erect or flattened, richly innervated by sensory nerve endings, which makes it the most sensitive part to tactile stimulation, erect during sexual arousal. Areola, on the other hand, it is circular pigmented surrounding the base of nipple. It has modified sebaceous glands, produce oily secretion, lubricates nipple and areola, and prevent from drying and cracking. During pregnancy, it becomes darker and enlarged. So we are done with skin. Now we are going to the stroma. Stroma of the breast consists of connective tissue and fat. So stroma contains connective tissue and fat. It forms the supporting framework of the breast. Okay, the connective tissue will condense to form fibrous strands or septa called as suspensory ligaments of Cooper. So this is an important word over here. So you have to write about suspensory ligament of Cooper, which is nothing but condensation of the connective tissues. The connective tissues condense to form fibrous strands called suspensory ligaments of Cooper. These are arranged in radial fashion. They are going to connect the dermis of the overlying skin to the ducts of the breast and pectoral fascia. So they maintain the protuberance of the breast, and their atrophy during aging makes the breast pendulous in the old age. So they are going to make the breast, they are going to support, okay, they are the supporting framework for the breast. So first point you will be writing, it is a connective tissue. So the stroma is going to contain connective tissue and fat, so that it is a supporting framework. So what happens, these connective tissue, they are going to condense to form suspensory ligaments of Cooper. These suspensory ligaments of Cooper are arranged in a radial fashion, and what is their function? They are going to connect the dermis of the overlying skin to the duct of the breast. Okay, so that they are holding the breast, they are giving some protuberance to the breast. So during aging, what happens? There is atrophy, that is these suspensory ligaments of Cooper starts to get atrophied and it starts to get degenerated, so that the stiff supporting framework is lost, and during old age the breast becomes pendulous. Now the fat forms the most of the bulk of breast. It is distributed all over the breast except beneath the areola and the nipple. So except beneath areola and nipple, most of the bulk of the breast is just fat. So we do not have fat just beneath the areola and nipple. So other than that, everywhere fat is present in the breast. So that should be a point to remember. Okay. Next, parenchyma. So we have seen about the skin, the stroma, and finally coming to parenchyma. Parenchyma or glandular tissue of the breast secretes milk to feed the newborn baby. So this is the important part. They are going to secrete milk to feed the newborn baby, and there are 15 to 20 lobes which are arranged in radial fashion. Okay, each lobe is divided into lobules, and that consists of cluster of acini. Each lobe is drained by lactiferous duct. Okay, and then these converge towards the nipple and open at its summit. So lactiferous sinus, near the termination, it is going to expand into lactiferous sinus, which acts as a reservoir of milk during lactation. So what happens? The parenchyma, it is going to secrete milk. Okay, so totally we have 15 to 20 lobes. So where are these lobes? So this is structure of one single lobe. Okay, so like this you have 15 to 20 lobes. Okay, 15 to 20 lobes, they are arranged in radial fashion. So each lobe is divided into lobules. Okay, so in each lobe we have here, you can see the lobules. So each lobe, so this as a whole is a lobe, and inside it is divided into lobules. Each lobe is divided into lobules that consist of cluster of acini. So these round thing are the acini. Okay, so lobes are divided into lobules, and each lobule is going to have clusters of acini. Clusters of acini. Each lobe is drained by a lactiferous duct. So this duct over here is the lactiferous duct. Okay, so it is going to be drained by, so each lobe is going to be drained by the lactiferous duct. Now they converge at the nipple and open. So before, near its termination, you can see it expands into lactiferous sinus, where it is going to act as a reservoir of milk. So this bulged portion over here, this is lactiferous sinus. So this will act as a reservoir of milk. Okay, so it is going to just store milk, reservoir of milk during lactation. So this is one lobe. Like this we have 15 to 20 lobes. Okay, each lobe has many lobules, and each lobule has clusters of acini, and they are all going to drain into the lactiferous duct. Before opening into the nipple, the lactiferous duct is going to expand into lactiferous sinus, which acts as a reservoir of milk during lactation. So this is the structure of lobe of the mammary gland. So male breast is also going to resemble a rudimentary female breast. So male breast is devoid of lobes and lobules. So these lobules and lobes are absent in the male breast. Its small nipple and areola lie over the fourth intercostal space. So for females also, nipple lie over the fourth intercostal space. So this was about the structure of breast. So in the structure we saw about the skin, stroma and parenchyma. In skin we saw about the nipple and areola. Right. So what is this diagram? Here we have the clavicle, pectoralis major. The green color is pectoral fascia. We have the lobes here, lobes of the breast, and lactiferous sinus finally opening through lactiferous duct. Here we have the ligaments of Cooper, which are going to provide a structural framework to the breast. Okay, they are going to give protuberance to the breast. So in the old age, when this gets atrophied, we can see pendulous breast. Okay, the sebaceous glands in the areola are enlarged during pregnancy and appear small nodular elevations. These are called as Montgomery's tubercles. Okay, so Montgomery's tubercles, we saw here, we have modified sebaceous glands in the areola, right? So during pregnancy, they will start to enlarge and appear as small nodular elevations. So that elevations we call it as Montgomery's tubercles. So this was about the structure. So we saw the introduction, location, shape and extent, relation, structure. Now coming to arterial supply. So what arteries supply the breast? Breast is a highly vascularized structure. Okay. So there are 5 arteries that are going to supply the breast. So you can draw this diagram for arterial supply of blood. Starting off with internal thoracic or mammary artery. So we have internal thoracic artery over here, which is also called as mammary artery. Through the perforating branches pierce the 2nd, 3rd, 4th intercostal spaces. So 2nd to 6th only we have our breast. So 2nd, 3rd, 4th intercostal spaces, these arteries are going to pierce. Next is the lateral thoracic artery. Here we have the lateral thoracic artery. Lateral thoracic artery is a branch of axillary artery. Then posterior intercostal artery through their lateral branches. Posterior intercostal arteries. So here we have the lateral branches of posterior intercostal arteries. Then we have the pectoral branch of thoracoacromial artery. Pectoral branch of thoracoacromial artery or acromiothoracic artery, both are the same. Okay, pectoral branch. And then superior thoracic artery. Then we have the superior thoracic artery. So remember, with the name thoracic itself, you have like 4 arteries. Okay, internal thoracic, lateral thoracic, and superior thoracic. Okay, internal thoracic artery, also called as mammary artery. And then you have the lateral thoracic artery, posterior lateral branches of posterior intercostal arteries, pectoral branch of thoracoacromial artery, superior thoracic artery. So, okay, these are the arterial supply. Just you can remember this diagram, starting off with internal thoracic artery, and then superior thoracic artery, acromiothoracic artery, lateral thoracic artery. Remember, superior thoracic artery, acromiothoracic artery, lateral thoracic artery. Then we have the lateral branches of posterior intercostal artery. So artery supply is done. Coming to venous drainage. So venous drainage, we have the following veins: axillary vein, internal thoracic vein, posterior intercostal vein. So same like here, internal thoracic artery we had, internal thoracic vein. So here we had axillary artery, from which we had superior thoracic, acromiothoracic, lateral thoracic, everything. Here we have internal axillary vein. Okay. So next is posterior intercostal veins. Here we had posterior intercostal artery. Here we are having posterior intercostal vein. So the veins follow the artery. First they converge at the base of the nipple, forming an anastomosis called venous circle or venous plexus of Haller. And they run superficial to deep. Superficial veins are going to drain into the internal thoracic vein. Deep veins drain into internal thoracic, axillary, posterior intercostal veins. Okay. So we have 3 veins: axillary vein, internal thoracic vein, posterior intercostal vein. Superficial veins are going to drain into internal thoracic vein. The deep veins are going to drain into all the 3, that is axillary vein, internal thoracic vein, and posterior intercostal veins. Now, next, apart from lymph vessels, cancer breast can also spread through segmental veins. Here it is important to know the veins draining the breast communicates with the vertebral venous plexus. So we all know that cancer can spread through the venous, through the lymphatics. Sometimes it can also pass through the veins. So metastasis of breast cancer, when a breast cancer patient, the cancer can metastasis from breast to the brain. So through what route the cancer is going to travel? So that is, cancer cells from the breast goes through posterior intercostal veins into the vertebral venous plexus, intracranial dural venous sinus, and then brain. So this pathway is important for the traveling of cancer. Okay, the cancer cells from the breast through posterior intercostal veins, it goes and communicates with the vertebral venous plexus. If it goes to vertebral venous plexus, it will reach the intracranial dural venous sinus. From intracranial dural venous sinus, it will reach the brain. Okay. Next, coming to the nerve supply. Nerve supply of the breast is primarily somatosensory. It is derived from 2nd to 6th intercostal nerves, because the breast extent is from 2nd rib to the 6th rib. So obviously the nerves from 2nd to the 6th intercostal ribs are going to supply the breast. Okay. So it is somatosensory, derived from 2nd to 6th intercostal nerves, and nerves provide sensory innervation to the skin and carry autonomic fibers to the smooth muscles and the blood vessels of the breast. Okay, so we have sensory nerve endings in the nipple and areola, right? They are going to play a major role in stimulating the release of milk from the mammary gland in response to the suckling action of the infant. The sensory nerve endings in the nipple and areola. So the secretion of milk from the breast is not under neural control, but it is enabled by the prolactin hormone that is secreted by the pituitary gland. Okay, so secretion of milk, only ejection of milk can be done by sensory nerve endings. They stimulate the release of milk, ejection of milk in response to the suckling action. But secretion of the milk is not under the neural control. It is under the hormonal control. Prolactin hormone, which is secreted by the pituitary gland. So according to that, secretion of milk will take place. Finally, we have the lymphatic drainage. So lymphatic drainage of the breast is a very important topic because cancer cells can metastasize through these lymphatics. Okay, because for the carcinoma of the breast cancer, they can spread. So lymph nodes, lymphatics draining the breast, we are going to see right now. So the lymph nodes draining the breast, we have axillary lymph node, internal mammary nodes, supraclavicular, posterior intercostal, cephalic nodes. So 5 nodes we have to remember. One is the axillary lymph node lying in the axilla, and it is divided into 5. So starting off with axillary lymph node. So here we have the axillary lymph nodes. Okay, axillary lymph node. So in the axilla area you have, so starting with apical, the topmost, apical, central, lateral, anterior, posterior. Okay, so these 1, 2, 3, 4, 5. These 5 groups of lymph nodes come under axillary lymph node. So we have apical lymph node, axillary, starting off with apical, central, lateral, anterior, posterior. Okay. Then we have internal mammary node lying along the internal thoracic vessel. So here we have internal thoracic vessels, and so we have internal mammary lymph nodes. Okay, so we have internal mammary lymph nodes here. Then supraclavicular, lying above the clavicle. Supra means above, clavicular means clavicle. So supraclavicular is going to lie above the clavicle. We have supraclavicular lymph nodes. Posterior intercostal nodes, lying in posterior part of intercostal spaces in front of the head of ribs. So here we have posterior intercostal nodes. Posterior intercostal artery also we saw at this region, right? So posterior intercostal nodes are also going to be present in the same region. Cephalic or deltopectoral nodes lying in the deltopectoral groove. So here we have the deltopectoral node. So remember this diagram. For axillary lymph nodes, we have apical group, central, lateral, anterior, posterior. Next we have internal mammary nodes, posterior intercostal nodes, supraclavicular nodes, deltopectoral nodes. Done? Next we have the lymphatics draining the breast. We are dividing it into superficial and deep. Superficial lymphatics drain the skin of the breast except nipple and areola. So whole skin of the breast is drained by the superficial lymphatics, but it does not drain the nipple and areola. Deep lymphatics, they are going to drain the nipple and areola part. Okay, a plexus of lymph vessels deep to the areola are called subareolar plexus of Sappi. Okay, so this is again an important point, subareolar plexus of Sappi. The subareolar plexus and most of the lymph from the breast drain into the anterior group of axillary lymph nodes. The superficial lymphatics of the breast of one side communicate with those of the opposite side. Okay, so the superficial lymphatics of the breast from one side, it will communicate to the opposite side. So there is unilateral malignancy may become bilateral. So when there is one side cancer, it can become bilateral because of this communication to the other side. Now lymphatics that drain the breast, okay. So what are those? The lymph from the lateral quadrant of the breast is drained into anterior axillary or pectoral lymph node. So this is, so before that we are going to see the subareolar plexus of Sappi. So here you can see the anterior axillary nodes, and here we have the nipple around which we have the subareolar plexus of Sappi. So this diagram can be drawn to show that. So lateral quadrant drain into anterior axillary or pectoral group of lymph nodes. Here we have the lateral quadrant. Lateral quadrant is drained into the anterior axillary. So this is anterior axillary. Okay, anterior axillary and the pectoral group of lymph nodes. These lymph nodes are situated deep to the lower border of the pectoralis minor muscle. Okay, from the lateral quadrants. From the medial quadrants, it will be drained into internal mammary situated along the internal mammary artery. Okay, and it can also communicate to the other side. So medial quadrants, they are going to drain into the internal mammary lymph nodes, and they also have the ability to cross over and go to the other side. Okay. Next we have a few lymph vessels from the lower lateral quadrant of the breast follow the posterior intercostal artery and drain into posterior intercostal nodes located along the course of the artery. Few lymph vessels in the posterior lower lateral quadrant of the breast. So where is lower lateral? So this is LL, that is lower lateral. It is going to drain into posterior intercostal lymph nodes. Right, so from lower lateral to posterior intercostal lymph nodes. Now lower medial cross the costal margin, pierce linea alba and communicate to subdiaphragmatic subperitoneal lymph plexus. So see here, from lower medial it crosses the linea alba and goes to the subperitoneal lymph nodes. Okay, subperitoneal and subdiaphragmatic. So below the diaphragm and it goes to subperitoneal lymph plexus, the lower medial quadrant. The lymph vessels from deep surface of the breast pierce the pectoralis major, clavipectoral fascia and drain into apical group. From the deep surface, they are going to pierce the pectoralis major and the clavipectoral fascia to drain into apical group of lymph nodes. So they are going to drain into the apical group of axillary lymph nodes. Okay, so this diagram can show the paths of the lymphatics. Okay, so remember, from lateral quadrants, anterior axillary or pectoral group of lymph nodes. From medial quadrants, internal mammary or parasternal lymph nodes. And it can also go to the opposite sides. From lower lateral quadrants, it can go to posterior intercostal artery, posterior through along the following the posterior intercostal artery into the posterior intercostal nodes. Obviously, lymph cannot drain into artery, right? It will drain into lymph nodes. So posterior intercostal node. And then few from the lower medial, they cross the linea alba, they communicate with subdiaphragmatic and subperitoneal lymph plexus. And then lymph vessels present in the deep surface, they are going to pierce the pectoralis major, clavipectoral fascia and drain into apical group of axillary lymph nodes. Right. Now 75% of the lymph from the breast is drained into axillary node. Okay, so axillary node 75%, internal mammary 20%, 5% to posterior intercostal lymph node. So you can remember axillary is more common because we have axillary, we have apical, central, anterior, posterior, lateral, right? So 75% of the breast is going to drain into axillary nodes, 20% into internal mammary lymph nodes and 5% to posterior intercostal lymph nodes. Okay. Now this diagram, it is important. Next we have so lymphatics where they can go, internal pectoral lymph node, and then we have the clavipectoral fascia. Crossing that we have apical group of axillary lymph nodes, axillary artery, axillary vein. So final topic for our essay of breast is clinical correlation. So we have to end every answer with a clinical correlation. So for breast, obviously it is going to be about cancer, carcinoma, right? So breast cancer is most common in females. It arises from the epithelial cells lining the lactiferous duct or acini of lobule. 60% cases. Upper lateral quadrant is more common. that affects the female between ages of 40 to 60. Upper lateral quadrant. This is upper lateral quadrant. So this is mostly, okay, mostly this upper lateral quadrant is going to get affected. Okay, upper lateral quadrant in 60% of the cases. Now, clinically presents a various serious problems with signs and symptoms. So, what are the signs and symptoms of breast cancer? Presence of painless hard lump. So, first point, there is painless hard lump. The breast becomes fixed and it becomes immobile. That is, movement of the breast is going to be restricted due to infiltration of suspensory ligaments by cancer cells. So we saw suspensory ligament of Cooper. So they are going to give a support to the breast, right? Now the breast is becoming fixed and immobile because the cancer cells have entered the suspensory ligament. Okay. Next is retraction of skin due to infiltration of suspensory ligaments by cancer cells. So here the thing to note is, first, it becomes fixed or immobile because of infiltration into suspensory ligament, and retraction of skin is also due to infiltration into suspensory ligament. Retraction of the nipple is due to infiltration into fibers of the lactiferous duct. Peau d'orange appearance. So peau d'orange is this orange color appearance of the breast. So the picture is not here. It is orangish appearance of the, or it appears like an orange. Okay. Skin giving appearance like the skin of the orange. It has pits of hair follicles appear to be retracted beneath the level of skin due to obstruction of superficial lymphatics. So here, starting off with painless hard lump is the first point. Next is, when something when the cancer is infiltrating into suspensory ligament, okay, suspensory ligament, we have two problems. One problem is the breast is going to become fixed and it is going to become immobile. The second problem, there is going to be retraction of the skin. This is because of infiltration into suspensory ligament. But when there is infiltration into lactiferous duct, fibrosis of lactiferous duct, that is when retraction of the nipple is going to take place. Okay, so retraction of the nipple is during lactiferous duct. Retraction of the skin is due to infiltration into the suspensory ligament. So just remember those two. Okay, retraction of skin when it is getting infiltrated. So skin, suspensory ligament. Yes. Okay. So skin, suspensory ligament. But when there is retraction of nipple because of infiltration into the lactiferous duct. Now this peau d'orange, it is because pits of hair follicles appear to be retracted beneath the level of the skin because of obstruction of superficial lymphatics. So superficial lymphatics, when they get obstructed, okay, obstruction of superficial lymphatics is going to cause peau d'orange appearance. So these are the points to be remembered. Painless hard lump. When it is getting infiltrated into suspensory ligaments, two problems. Breast is going to get fixed and immobile. Retraction of skin. Skin, suspensory. Yes, remember that. When retraction of nipple takes place, when it is getting infiltrated into the lactiferous duct. Peau d'orange is when obstruction of superficial lymphatics. The pits of hair follicles appear to be retracted beneath the skin. Okay. Next is metastasis. The knowledge of lymphatic drainage of breast great important due to high percentage of occurrence of the cancer. So here some lymph from the inferomedial quadrant is going to communicate with the subperitoneal lymph plexus. We saw that, right? Subperitoneal lymph plexus and carry the cancer cells. They get producing a secondary tumor in the ovary called as Krukenberg's tumor. So Krukenberg's tumor, here we have this Krukenberg's tumor. So some from the medial, okay, lateral medial quadrant, those lymphatics are going to communicate with the subperitoneal lymph plexus. When they communicate with subperitoneal lymph plexus, from there it is going to the ovary. So in the ovary, there is a secondary tumor developed because of this, called as Krickenberg's tumor. Okay. So early detection of breast cancer, serious fatal in women. So mammography and self-examination can be done. So these two are the early detection. One is mammography, another one is self-examination. Mammography is nothing but X-ray examination in order to detect breast cancer. Okay. Self-examination can be done by the patient or by the person by themselves. They can stand in front of the mirror. They can inspect both the breast for any discharge from the nipple. If there is any discharge, obviously they have to consult a doctor. Clasp hands behind the head and press the head forward. Press hands firmly on the hip and slowly forward. So the gentle squeeze the nipple, look for any discharge. So all these are the self-examination. Okay, so what are the early detection of breast cancer? It can be either through mammography, which is X-ray, or regular self-examination can be done. Now, what is the treatment? Treatment is lumpectomy, mastectomy. What is lumpectomy? It is removal of only the tumor. Mastectomy is the removal of one or both the breast itself. So the classical operation of radial mastectomy, the whole breast is removed along with the axillary lymph node, pectoralis major and minor muscle. Okay, so this is the final treatment. So as of now, the breast part is over. So we saw the introduction, location, shape and extent, relation, structure, arterial supply, venous drainage, nerve supply and lymphatics, and finally ended it with clinical correlation. So this is about the mammary gland. So thank you. Please like, share and subscribe.